We are so grateful for Dr. Peel to come to us with all of her expertise and share her insights and her knowledge. We will be having another presentation the end of March with a Dr. George Kim, and he'll be speaking on MAID and dementia. So that's March 26th, 1/3. That will be on our social media and on our website as well. We will certainly be advertising that. So yeah, we have started recording, and welcome, Dr. Peel. Dr. Peel is a geriatrician. We are so fortunate to have her servicing our areas of Huron and Perth County. A whole lot of communities across Canada simply don't have, I would say, the luxury and the benefit of having a geriatrician available in their area. She's also chair of the Senior Care Gateway Center of Excellence in Rural Health. She's an adjunct professor for the Division of Geriatric Medicine at Schulich School of Medicine and Dentistry. She's also adjunct professor at the School of Pharmacy, University of Waterloo, and the Physician Advisory Council member for the Huron Perth, our local Ontario health team. Many hats, and all of them well worn. So thank you and welcome, Dr. Alexandrea Peel.
Did you get closed captions?
No.
If you go on your iPad, you'll be able to get them. I'm on my tab.
Could you just mute again? Okay, perfect. All right, so thank you everyone for coming. Just get our slides rolling here. So I recognize that, the topic we're going to cover today, medical decision making in dementia, can make a lot of us feel a little uncomfortable. But I just want to reassure everyone that the goal of today is really to prepare you so that you can get the best possible care. Because the reality is, although at some point all of us will pass away, very few of us have had any conversation with our doctor or anyone about what the future holds. And that kind of puts us at a bit of a disadvantage. The other kind of word you'll hear throughout this presentation is palliative care or palliative approach to care. And I just, again, just want to reassure you that, the analogy is that palliative care is the umbrella, not the rain, right? So talking about end of life doesn't make it come any sooner, but it just helps prepare us for the future. The other piece I would say is that we're all, no matter what, we're going to hope for the best, but this kind of a talk helps us plan for the rest of things. If you would like more information, in addition to what we're going to talk about today, a couple of good links here. One is to the PATH program, which was a program developed in Eastern Canada called Palliative and Therapeutic Harmonization in the context of chronic disease. They have a lot of good resources, and also this excellent book, podcast, and website, Hope for the Best and Plan for the Rest, 7 Keys to Managing a Life-Changing Diagnosis. So a couple of great references to point you to. So in terms of objectives for today, the first objective is to help you to make medical decisions in the context of having a diagnosis of dementia. And the second big objective is to help you kind of understand this palliative approach to care and how it's very relevant to anyone who has any illness that cannot be cured. And just in terms of our roadmap, as Christy mentioned, there is another talk in March that is dedicated towards the very end of life and medical assistance in dying. So today we're really going to talk about that time from a diagnosis and the journey forward. So why is this conversation important? 1 in 3 Canadian seniors will die with dementia, right? So this is really relevant to many of us. And I think also kind of recognizing that dementia can be a terminal problem, right? I think a lot of times we think about it as an illness that affects memory and thinking. But in the end, it can be just like cancer, heart disease, or liver or kidney disease. The other thing to kind of remember is just that, many people are passing away in Canada every year, and over 3/4 of them, it is due to a chronic illness. And so they're very rare is it that people are actually accessing, true palliative care services. The majority of us are dying without access to palliative care services. And so we need that palliative approach to thinking throughout the course of our illness. So one of the first questions that I will get asked sometime after a diagnosis of dementia is made is, what is my dementia prognosis? And I like to think of the answer in the terms of timeline and storyline. And timeline refers to how much time does a person with this illness typically have? And storyline refers to what's going to happen to this person throughout the course of their illness. And you kind of need both to be able to provide them any accurate information. So in terms of timeline, or how long someone is going to live, many times when you try to ask your doctor about your prognosis, they will give you this kind of timeline answer, like, the average person with Alzheimer's disease lives 8 to 10 years from the time of diagnosis to death. But that timeline information is incomplete without the storyline information. So in terms of what the variables are, in terms of the storyline of what's going to happen from that diagnosis, there is the storyline of the dementia process itself, which we will talk about. There is the storyline of a person with frailty. Oh, I have lost my slides. Have you lost your feed as well, Jeanette?
Yes, we can't see your slides. We see a beautiful picture of your children, but we can't see your slides.
Well,
I think you may have to reshare.
My whole PowerPoint shut itself down, so you just have to give me
Okay.
a second here. My apologies. I've never had that before.
No problem.
I am just recovering the file, and hopefully all will be well.
Maybe I'll just pause the recording. Oh, there we go. Good.
So we'll just skip to we were chatting. Okay, so hopefully we no more crises.
Okay.
So in terms of those storyline variables, we were talking about the storyline of the dementia itself, and we will kind of touch on that. We will talk about the storyline of frailty in general, which takes into account cognitive frailty, which is the memory problem or the dementia, but also someone's function. And then the other piece that's important that we're going to kind of touch on is the timeline and the storyline of other health problems that a person might have and how that might affect their dementia storyline. So in terms of the storyline of dementia, we often talk about it in terms of stages, and you'll hear early stage, middle stage, late stage, end stage. Early stage is someone that is pretty independent, but they're probably having some changes in cognitive function, mood, behavior. The middle stage is someone that certainly needs some assistance with their activities of daily living. So like transportation, finances, meals. They might also be needing some early reminders around their personal care. And of course, they're having mood, cognitive, behavioral changes as well. The late stage is someone that is dependent for all of their activities of daily living. They might be starting to experience problems with incontinence. They're often needing round-the-clock kind of supervision. They might start to have some mobility impairments. And then we're talking about the end stage, where someone might have swallowing, nutrition, and hydration problems. There's often more time spent sleeping. They're often totally dependent for their activities and often have mobility impairment. And I think, one of the things when I'm seeing people is that we're always trying to make sure that what we're seeing is not due to some other medical thing, and that it is kind of ruling that out before we say that symptom would be due to dementia. So kind of thinking about that storyline, we think of this type of a graph where we have function on the y-axis and we have time on the x-axis, and over time that function declines very gradually. But how is that different when someone is becoming frail? So in terms of what is frailty, frailty is sort of our accumulation of health problems. We think of it in terms of how someone is physically, like their mobility, walking. We think about frailty in terms of their cognition, and we think about it in terms of their ability to handle daily tasks. So as an example, you could have a person that has dementia, high blood pressure, and high cholesterol, but the person on the left side has a much different storyline to the person on the right side of the screen. So we need to be taking that sort of frailty into consideration when we're trying to help guide someone around their prognosis. Why is it important? Someone who is more frail is just more vulnerable. They can't recover from illnesses as quickly as someone who is more fit. It also predicts how we're going to do if we have surgery, or if we have a medical treatment, or if we're hospitalized. And, it can be progressive, so it's going to change over time. In terms of the storyline around other illnesses, this is something that, can make understanding your prognosis a little bit more difficult. But what I kind of often explain to families is kind of something along this line, where normally the storyline of dementia is sort of that gradual progressive change through the stages. But if someone has other health issues, such as heart disease, lung disease, kidney disease, liver disease, etc., they'll often experience kind of sudden deteriorations. They might have functional decline during that time. They might have delirium, and many people won't recover to their previous baseline. So all this to say, if your other health problems are kind of building up on you, it will affect your dementia storyline. And that relates a little bit to what I wanted to touch on around the harm of hospitalization in older people. So when an older person or a frail person or a person with a memory impairment goes into the hospital, they're at risk of delirium. And about 1 in 3 people admitted for a medical issue will experience delirium. Up to half of people who are admitted with a surgery will experience delirium, and almost 3/4 that are in the intensive care unit will experience delirium, and many don't make recovery. Functional decline is also very common in people that are hospitalized. So you can lose about 5% of your muscle mass for every day that you're not walking around. So you can imagine by the end of a week in hospital, you have a very significant change in your strength and physical function. Incontinence can happen in up to 50% in hospital, and it's not always fully reversible. Falls are common, and pressure injuries, or also known as bed sores, are also very common. When you add all of these things together, right, people with frailty and memory impairment often have longer stays in hospital, a higher risk of death, more functional decline in the hospital, and long-term care admission often becomes a product of hospitalization because of all these injuries that have occurred. So taking all of this together in terms of timeline and storyline, and in terms of all of those factors that affect storyline, there was a study published looking at Ontarians with a diagnosis of dementia. They followed them for 5 years. And what they observed is that at the end of that period, about a half of them had passed away, about a quarter were still living at home, and a quarter we're still in long-term care, or sorry, we're in long-term care. So sometimes that gives people just that little bit more information than just that initial timeline information, which is what a lot of people get. Now, the next question that people will often ask is, oh, geez, like, a lot of people are passing. Like, what is that? A lot of times it's infections, maybe pneumonia or urinary tract infection, or sometimes a wound. Falls with injuries, so like a bleed in the head or a hip fracture or a spine compression fracture are common. And then just other things that affect frail people, so like heart disease, lung disease, strokes, etc. So a couple of cases, just to kind of illustrate some of these things we've discussed. So this is an 83-year-old man. He's in sort of that moderate stage of dementia where he's needing some help with his activities of daily living. He's also got kidney disease and heart disease. Suddenly, he comes down with pneumonia, and thankfully, he responded really well to antibiotics. Unfortunately, his chest X-ray also showed an early-stage lung cancer, and he was told that if he had surgery for this early-stage lung cancer, he would be cured. And he decided to have surgery, thinking that it would, preserve good quality of life as long as possible. Unfortunately, after surgery, he was delirious. He received a lot of medications to help try to calm him down. He had a fall, and then they were using physical restraints to, make sure that he didn't fall anymore in the hospital, which led to a lot of deconditioning and functional decline. He had a long hospital stay, and he went to rehab, but he just never really recovered and ended up having to move to long-term care. And I tell you this, not to make you feel fearful of hospitals or not want to go to hospitals, because that's exactly where you should go if you need it, right? But what we failed to consider in this case was, the frailty that he had prior to this diagnosis, and that, people with dementia can look okay, but they are more fragile and they can't always recover. In hindsight, if we think of that study of Ontarians, his life expectancy was already limited by his dementia and his heart disease and his kidney disease. And so removing his cancer, though on paper we think that's extended his life, it probably didn't, right? Because people can live for many years with an early stage lung cancer before it would ever become something that, would cause them symptoms. Another example is this 83-year-old lady, also with moderate stage dementia, so needing a little bit of help with her activities of daily living. She also has some underlying kidney disease. She comes to the emergency department with a urinary tract infection. After a long stay, because it's busy and there's lots of things going on, she's starting to become very delirious. And so she's not able to go home. So she's admitted to the hospital. Unfortunately, she gets more delirious and she's becoming more anxious and agitated. They're using some medications to try to help keep her calm. She's trying to get up, so then they're using some restraints to keep her from falling. Again, she experiences some functional decline. She tries to do rehabilitation, but again, things just don't recover. And ultimately, she ends up requiring long-term care. And again, what I'm trying to kind of illustrate with this case is that, in this case, this woman had a urinary tract infection. Her only option was to go to the emergency department. We want to have these important conversations so that we can develop alternative ways of seeking care when we know, what people's goals actually are. And we'll touch on some alternative kind of pathways of it. So, just in terms of general questions to ask when you are kind of making a medical decision, whether it's about, a treatment or whether it's about a surgery or, a hospital stay or whatever it is, always kind of asking, will my frailties, will my memory problem make this risky? How can my symptoms be effectively managed? Will I have to go to the hospital? For how long? Will this treatment make me worse in terms of memory or function? Will it give me more good quality years, especially years at home, right? If the decline in my health cannot be reversed, how can we promote my comfort and dignity, right? And then the last question, which sometimes comes up, is, should we now be thinking about planning a peaceful and meaningful death, right? And we'll kind of talk about when that question is something you might ask. So I'm going to kind of shift gears and talk a little bit more about this palliative approach to care and kind of what you might do. So this concept of care versus cure, right? So our society is very focused on kind of fighting disease and finding cures. We are making tons of medical advances that are saving and extending people's lives. But sometimes these treatments to lengthen life actually reduce our quality of life. And we just want to make sure that when we have an illness that can't be cured, we're always thinking about the best way to care for the person rather than the best way to cure the person. So this concept of a palliative approach to care is becoming a lot more popular in terms of the healthcare provider context. So it includes treatments to cure or control your illness. So it's not like an exclusive thing, but it also means that we take a focused approach to meeting the person and their family's physical, social, spiritual needs at all stages of the illness. It also kind of focuses on care of the whole person, improving their quality of life, supporting them and their caregivers. So kind of a little bit of a roadmap on kind of how this plays out. Like a lot of people think palliative care, they think that small bubble, right? They think sort of like end of life care, management of symptoms in last days of life. Or sometimes they think about palliative care services in our community, like the palliative care outreach team or the hospice, which are kind of that second bubble. Those are kind of the services that are there in our last 6 months to a year. But this idea of palliative approach to care, again, is kind of, communicating, recognizing symptoms, and supporting people with dementia or any chronic illness throughout the course of their disease. So again, though, in terms of the components, that communication, so talking about goals, talking about advanced care plans, talking about what if, talking about symptom management, prevention of symptoms, what to anticipate, those types of things, and then supporting the person and their caregivers. So in terms of like who is providing this care, right? Because a lot of people are like, where do I even go for this, right? The idea is that everybody in the healthcare system should be supporting people with this kind of approach. So you'll look at kind of the bottom of the pyramid, and that's the foundation of this approach, right? So we should get that from our family doctor, our nurse practitioner, all of our home care team providers, like our care coordinator, our long-term care setting, which we live, or a retirement home. Ideally, they would be, supporting us with this way of approaching our care. The next level is all those specialists that we're seeing. So whether that's, the Alzheimer Society support counselors that specialize in helping people with memory impairment, whether that is the emergency room doctor that you're seeing, or the surgeon that's proposing a treatment to you, or the geriatrician, or, a specialist that you're seeing for one of your other chronic conditions. And then sort of that third level of the pyramid is kind of people that are nearing sort of end of life. And that's where some of these specialized palliative services become involved. So you'll hear of PCOT team or palliative care outreach team, which provides end of life care to people in their home, or you also hear of hospice. Now, the challenge with this, right, is when something is everyone's responsibility, sometimes it's no one's responsibility. And I'm hoping through conversations like this, we can kind of change that and move that forward. And I'll give you some tips on kind of what to ask your healthcare providers. So that palliative approach to care, we want to be personalized. We want to customize our order, so to speak. and we want to be proactive. We want to anticipate what's going to happen and try to put, a safety net plan in place for that. So what can you say to your doctor or any healthcare provider? You can say, okay, well, thank you for coming. Thank you for all that information you've provided me. But here is what matters most to me and my loved one. Or here is what you need to know about me or my loved one to provide us the best possible care. Or things like, at this stage, I'm worried most about X, Y, or Z. Or at this stage of our journey, I'm really hoping for whatever that is. Or what if situations I am worried most about are. And oftentimes these types of questions are a jumping off point for more detailed discussion. So some of the what if situations that I find often arise in my clinic, the first one is that what if around long-term care. Like, we don't want my loved one to go to long-term care. My loved one wants to be at home at all costs, or everyone is telling me that my loved one needs a long-term care application. And so what do we think about with this? Well, I often will talk to people about, the most common reason for people to go to long-term care is caregiver fatigue and burnout, right? And it's not because caregivers just need to work harder or have more grit, right? It's that we need to have like a better system in place to help support them. So as an example, in the United States, they did a study where they enrolled caregivers, they provided them education and support, very similar to what's provided by our local Alzheimer's Society. And what they showed is that it delayed long-term care or LTC placement by 1.5 years, just from supporting their caregiver. Other things that have been shown to delay that long-term care placement and support caregivers are respite care. So that might be things like adult day program, overnight program, respite care in the home through home and community care, friends and family providing support, church family, social connections providing support. There might be private pay supports that you could put in place. Sometimes there's respite in long-term care. And there's also some therapies that can provide respite, like recreation therapy, music therapy, pet therapy. Another thing I'll talk with caregivers about is energy conservation. So, being a caregiver is often a full-time job. And so you want to save your energy for that and try to get help with some other things that kind of don't give you aren't as meaningful to you, let's say. So that might be cleaning support, meal prep support, snow maintenance, getting your loved one's hair done instead of, trying to wash it yourself if that's a struggle, maybe getting foot care, nail care, those types of things. There's probably many others that Christy and Jeanette could come up with. And it might be utilizing allied health supports, right? So for example, sometimes I'll have caregivers tell me, well, I'm really struggling with getting my loved one in and out of the car, or I'm really struggling with getting them down the stairs or into the tub or whatever it is. Well, that's where an occupational therapist, might be really helpful. Or if there's a communication problem or a swallowing problem, again, speech therapy might be helpful. Or if there's weight loss, nutrition issues, right, a dietitian, or say there's financial issues, say a social worker might be helpful. So just remembering to take advantage of some of these resources. So another what if situation, which tends to occur commonly, is acute illness. And that presents an extra challenge for people because you're often asked to make decisions very quickly and you often don't have all of the information. So what I will often go through with some of my clients is sort of this idea of an acute sickness action plan to try to avoid hospital. So for example, the action plan around delirium. So if your loved one begins to experience symptoms of acute confusion, this is what we will do. So for example, having their vital signs checked either by you or maybe a community paramedic service or a nurse, getting their blood and urine checked, reviewing their medications, talking about bowels and bladder, et cetera, so that we can try to kind of manage that without having to go to hospital if we can. Sometimes we'll have action plans around heart failure or around lung disease or around infections like pneumonia or urinary tract infections. So for example, that idea of, okay, you're going to have, if you get symptoms of a urinary tract infection, I want you to collect a sample, drop it off at the lab, and we'll have a standing prescription of antibiotics that you can just start. And then I'll call you when I get those results, right? So some of these things we can avoid that long emergency stay or hospital stay. Another what if situation that we'll talk about is, my loved one hopes that they would pass away in their sleep. And, for many people, they don't realize that, say someone did pass away in their sleep, you would usually call 911, the firefighters would roll in. They operate under a medical directive, right? So their job is to try to bring people back at all costs. And for many people, they actually wouldn't want that, at a certain stage of their disease. And so this is a form that you can complete with any healthcare professional. The person with dementia or their substitute decision maker can sign this form, because I often have a lot of people ask, well, my loved one can't really understand this anymore, so maybe we can't do this. And I say, no, it's substitute decision maker could do it as well. But this is something you would want to have on hand for that type of a situation. You might take that up to hospital and apply it there, or you might not. It depends on the circumstance. But it was originally developed for use in the home. Another kind of what if people will ask me, like, when does my loved one need that last stage of care, that really end of life care? And one question you can kind of ask your family doctor to kind of get them steered onto that is, would you be surprised if my loved one passed away in the next year? Right? If they say no, it might be time to start thinking about that. Thinking about that timeline, we're thinking about the last 6 months of life-ish. From the storyline perspective, we're thinking about someone who's spending more time in bed, having more nutrition and hydration problems. They're probably fairly functionally dependent. And terminal agitation is another thing that I mentioned. I've had several patients with dementia who, towards the end of their life, can be very anxious, very agitated. We try to determine, like, are they in pain? Is there something medically wrong with them? Is this environmental, or how can we do things differently? And sometimes it's part of their disease, and it's a signal that they are nearing end of life. Other times where you might think about this end of life transition is, say a person is frail and they have an acute sickness, right? Sometimes it makes more sense to provide comfort-based care than care that will maybe extend their life, but not extend their functional life at home, right? Or a person is, frail and they also have a bunch of these other medical conditions, which, any one of them could be life-limiting at any point. So in terms of sort of another case discussion, this is a 74-year-old woman and she has advanced dementia. She also has some arthritis, neck pain, an abnormal heart rhythm, and high cholesterol. And her husband decided to kind of sit down with their family doctor and just have a discussion around, like, what the future holds and how to plan and what to do. So first they looked at her medications and they kind of decided that, really with how progressed her memory problem is, giving her a cholesterol pill is not going to, extend her quality or quantity of life. So maybe it's not appropriate anymore. But they thought that, pills for her heart or pills for pain were still appropriate. They didn't, want her to be in discomfort. They talked about that community do not resuscitate order. They talked about, acute changes that could happen in her health. So for example, if she were to fall and she were to have hip fracture, would they want her to have surgery, or would it be best in her case to manage her symptoms using medications or other treatments? They talked about, what, if anything medical happened, that they would want to treat, simple things that could be treated at home, but maybe forego complex medical treatments that might require hospitalization or cause more functional decline. They also talked about kind of end of life preferences and, if things changed, if things worsened, would you want to be at home or hospital or hospice? So all of these things are kind of conversations to have as things change with illness. So in terms of a summary, so in order to answer that question around like what is someone's prognosis, you really need to think about their big picture health status to help you kind of make decisions. So you want to think about their timeline and their storyline and their frailty and their other health conditions, and kind of put all that together to give you, good information. We talked about how when you have dementia and frailty, some treatments that are kind of meant to extend life can actually reduce quality of life. We talked about how dementia in and of itself shortens our life expectancy. It is a chronic condition. We talked about that palliative approach to care and how it focuses on, relieving suffering and supporting best possible quality of life. We talked about kind of customizing your order, letting providers know what matters to you, what you're most worried about, what you want to have a plan around. And we also talked a little bit about kind of engaging resources to support persons and caregivers to help keep people at home as long as possible. So I did receive 3 questions before the presentation. So I'll maybe shift over to kind of talking about those. So the first one is, how do you handle planning ahead when the individual who you are supporting thinks nothing is wrong with him or her and has not yet been deemed incompetent? So I thought this was a fabulous question. And these are some of the thoughts that I had about it. So what this person is asking about is this concept of anosognosia, which is lack of awareness of their condition. And this affects many people that have a diagnosis of dementia. So the first thing I would highlight is that, kind of as we talked about, a lot of the planning and education and support, you can do that on your own. You don't need, specific permission from the person with dementia to, activate those things. The next thing I would suggest is providing reassurance and kind of like framing this question of long-term care to try to reassure someone, right? And that is to say, my goal will always be to keep you at home. However, I want to have a backup plan in place in case anything happens to me or something changes with my health or your health. Because, this type of a statement is the reality, right? 95% of people do not want their loved one in long-term care. So, that kind of frames the conversation. The other thing I would suggest is, if your loved one really doesn't understand their dementia piece, try to hook it onto something they do understand. So for example, if you have another stroke, you might need more care. I want to make sure we have options. Or if you have another heart attack, you might need more care. I want to make sure we have options. Rather than saying, because of your dementia, I want to make sure we have more options. A couple of other just tips that I thought of, thinking about that a capacity assessment for long-term care, like often that's a big stress for caregivers, right? Because the care coordinator from Ontario Health at Home has to come out and assess their loved one. And that's very, very stressful because the care coordinator is going to say, I'm here to assess your eligibility for long-term care, right? So some key things that can help is to speak to the care coordinator both before and after the visit, without your loved one, so that you can provide the full picture so that you don't have to say certain things in front of your loved one. So you could say something like, I want to include my mom in the meeting, but I also want to make sure the answers she provides align with reality. And I cannot say some of these things in front of her. The next tip I would suggest is to collect information on how your loved one actually manages their activities of daily living. Because in the assessment that's done, they ask a lot of pointed, questions about how much help does your loved one need? And it's really more from a physical perspective. And so sometimes you feel pigeonholed into those responses, and how it would be better to respond is by saying, with or using examples like, my loved one wet their bed and then slept in it. They need assistance with that. Or they fell and they forgot to press the call button, right? Rather than sometimes being pigeonholed into this very specifics of the questions that are asked. And again, that information ideally would be provided before or after, and not always in front of your loved one. This concept of deemed incompetent, I just wanted to make everyone aware that it's pretty rare that anyone would ever be deemed incompetent. Occasionally, we would have an assessment done by the Ministry of the Attorney General, where they'd be looking at sort of all the domains of capacity and, deeming someone capable or incapable for various domains. But that's pretty unusual. What's more common is that we're looking at each healthcare decision individually, and that's the responsibility of the healthcare provider who's proposing the treatment to do the assessment, right? And so that's that idea that your loved one might be capable to consent to toenail clipping, but not capable to consent to surgery, for example. And I would just add to that capacity to refuse a treatment is still capacity, right? So a person can't just say no, right? It's, let's say something is being proposed, the person with dementia says, oh, no, thank you, I don't need that. Technically, they have to be able to say, yes, I have a diagnosis of dementia. It affects me in this and that way. This treatment would affect me in this or that way. And so therefore, I'm choosing to proceed or not proceed, right? So just kind of, cautioning you a little bit around just them kind of saying no, right? That's a sign that the person who's proposing the treatment needs to be speaking to the substitute decision maker. So another example that would come up around this is like day program. So when we're trying to enroll someone for day program for either respite or for cognitive, stimulation, I would avoid saying something like, I would like you to go to day program. It's new and scary and we're going to be separated all day, right? And I would say something more like connecting it to a person they trust. So like our daughter said, or the doctor said, or the neighbor said that this would be a really good program for you. Or connect it to something they do understand. Like, this program is very helpful for rehabilitation when people have poor balance or heart issues or whatever it is that they might understand. Other things I would suggest are, avoid making a decision at the time of going on the wait list, right? Like often the wait list is very long. So let's just go on the list and then we can make a decision when they give us a call. And when that call finally does come in, I would avoid having like a big discussion about it, right? It would be more a day or two before saying, they have a spot in that rehab program today. I thought it would be good for us to try that together. It's so nice that we could go together and kind of try that out. So again, what I always kind of advocate for is, when someone has, a memory impairment, we want to promote, their autonomy and their decision making. But if they can't grasp the situation, then we have to help them to make, the decision which would be necessary for their health. So the second question that was put out is, if someone is exhibiting signs of short-term memory loss, is there a benefit to having a diagnosis? And are there any disadvantages to having a diagnosis? So in terms of benefit, I would say, the key benefit from my perspective is preventing decline or slowing decline. So when we see someone who's reporting a memory issue, the first step is to make sure that there is not something else medically wrong with them causing this memory problem, right? So it might be, maybe there's a medication that's, maybe they've been on it for a really long time, but now that their body's a little bit more frail, they're not really tolerating it anymore. Or maybe they've had a stroke and they need to have stroke prevention. Or maybe they're having low blood sugar from their diabetic medication and it's making them very confused. So we need to rule out medical things. The other piece that I think is important is kind of things around slowing decline, right? So we know, for example, treating your hearing loss will slow progression of a memory problem. Or, people that are physically, mentally, socially active will slow the progression of their disease. So if we don't bring it to attention, right, we're often not optimizing those things. The next benefit would be treatment, right? So, our treatments for dementia are modest, but, in the studies, people that are put on cholinesterase inhibitors, for example, 1 in 12 of those people will get less decline on their memory testing over a 6 to 12-month period. So, if your cup half empty, you're thinking, well, that's not great. But if your cup half full, right, then that's something that you might want for their loved one, especially if they don't have a lot of other medical conditions that would make treatment risky. Some people might be candidates for some of the novel anti-amyloid treatments, or they might want to participate in research. I think, you're missing out on support, both for yourself and for the person with memory impairments, right? Often you might be struggling with financial issues, legal issues, practical issues, emotional support. And if it's not identified that they have this condition, you're kind of struggling in silence in a way. And then just this whole planning and information, right? Is, you want to, again, have some of these plans in place so that you can have the best possible quality of life. And, if we haven't had these conversations, had this diagnosis, then we won't be able to really do any of that planning. In terms of maybe considerations, when talking about a memory impairment, so driving comes up a lot. So many people with dementia in the early stages can continue to drive safely. The problem is that by the time many people come to attention, they're actually more in like a moderate to severe stage. And the government has a lot of criteria around when to report someone's driver's license. And so sometimes you'll get a situation where someone, coming in worried about a memory condition, they want to have all of the workup done, but then they realize that their loved one is no longer eligible to drive. And, that's hard. So I think it's not that I don't think that's a reason to avoid assessment, right? Because it's far better to stop driving before there's, a car accident or something like that. But just kind of like preparing yourself, or even just asking, what criteria would you use? Do you think they'll meet that criteria? Do you think they'll not, right? Based on what you're seeing. And I guess that stigma, right? Some people fear that, having dementia might make them globally incapable, and that, they won't be able to make their own decisions anymore. And the reality is that isn't true. And we're trying to fight that stigma, right? But some people, that might be something they might think about. So the last question that I received in advance is, what happens if the person who wants MAID, so I guess someone made a request for medical assistance in dying, or MAID, and they're not cognitively able to acknowledge their request just prior to the scheduled event. And so I would highlight that there's going to be a speaker specifically on this topic, which is why we didn't cover it in great detail today. So the short answer is I would connect with your MAID provider. So the MAID provider and the person who have made the request for MAID have to make an advanced care plan for this particular situation. And there is a provision in the legislation called a waiver of final consent. And how that works is that the MAID provider and the person would fill out the waiver of final consent when the person is still able to express their wishes. And the provider would provide the MAID on or before that date if capacity is lost. I guess the long answer to that, right, is that if someone is very interested in MAID or medical assistance in dying, then you would want to refer them for that early in their diagnosis while they are still capable and can build a relationship with their MAID provider. Usually once you've connected into the MAID system, there will be periodic follow-ups with your MAID provider. And when there is a risk that capacity is lost, so when the provider is seeing that you are starting to have affected capacity, that's when they should be sitting down with you around this waiver of final consent. If that document has not been completed, and the person loses capacity, my understanding is that the ability to have MAID is no longer available. All right, so I will hand it back over to Jeanette and Christy, and we'll dig into some of the other questions, and I'll let them facilitate that.
Right, wonderful. Thank you.
Thank you very much.
Yes, so we've stopped recording now.